Thanks. Can you see the screen okay?
Yes, I can.
Okay, perfect. And I'll move it to a full screen presentation in just a few minutes. So thank you for that introduction. I do have just a couple of disclosures to talk to you all about. I do receive consultant fees related to some editorial service, which come to me directly, and for DSMB service, which go to my department. But nothing that I'm going to talk about today is going to include any information on unlabeled use of commercial products or anything investigational. And the disclaimer before we get started is that there are lots and lots and lots of things that I could talk to you all about when it comes to sample size and statistical design and how all of these things work together. But I only have an hour, and I know it's lunchtime, and that's a hard time to talk about statistics. So we're going to focus this talk pretty narrowly on the design of a superiority trial. What I mean by that is a two-arm randomized trial where the intention of the investigator is to show that one treatment is better than the other with regard to some primary outcome. And I am pretty specifically assuming that the deliverable that we're interested in is the p-value from a hypothesis test. There are lots of other trial designs, some of which are very relevant to the space, the early phase research space in which you all are working, where this may not be the scenario you're in. You may be thinking about a trial where the objective is not superiority. It might be futility, it might be non-inferiority. You could be looking at a deliverable that is not a p-value from a hypothesis test. Could be the selection of an agent from among a group of agents. It could be some evaluation of dose finding. It could be some estimate of precision. And in those cases, some of the factors that we're going to talk about here are still going to be relevant, maybe more or less so. Some of them are not going to be relevant at all. So please don't think that what we're talking about today is sort of everything that there is to know about this topic. It definitely is not. And then I'm going to show you, so the reason, and I love to start with this cartoon. If y'all have seen it, bear with me. It's just a few minutes long. A cartoon that shows why we want to have a lecture like this to avoid conversations like the one that you'll hear.
I have a study, and I need to know how many patients I need. I think I only need 3 patients.
Okay, what kind of study is it?
I'm doing a lab study. Can I just use 3 patients?
That depends. What are you trying to show?
We always use 3 patients.
Okay, what are you trying to show?
I'm trying to show that drug A and drug B are better than only drug A.
How are you measuring if it is better?
We are looking at apoptosis. Can we just use 3 patients?
What kind of measure of apoptosis? Do you know how variable that measure is?
We always use 3 patients. That is what we have published before.
3 patients per group or in total?
Yes.
Okay, let's try something different. What type of measure are you using? And is this an in vitro study? An in vivo mouse study?
It is an in vitro study of patient samples, and we are looking at measures of apoptosis after treatment with drug A and drug B versus drug A and control, and drug B alone.
Oh, how many groups are you analyzing altogether then?
My grant is due tomorrow. I just need to know if I can just use 3 patients per group.
Okay, well, you probably should have come to me earlier for help with this.
All I need you to do is tell me that 3 patients are okay.
So, it is not that easy. Your marker for apoptosis may have a large amount of variability associated with it that could make it difficult to ascertain differences based only on 3 patients per group. It also depends on what kind of outcomes you are looking at. Are you looking at normalized changes in expression levels from baseline? 3 patients may not be sufficient to detect differences in these expression levels between the different treatment groups.
I do not understand.
I'm saying that you may need more than 3 patients per group, but that I need more information to determine that.
The serine protease granzyme B is made in cytotoxic lymphocytes, where it is inactive due to the low pH of the storage granules. It is measured immediately upon delivery into target cell cytoplasms, where the pH is neutral. This is followed by cleavage of procaspase 3 by granzyme B in the target cell cytoplasm and the subsequent induction of apoptosis. All proteolytic events can be quantitated at the live single-cell level by flow cytometry and imaged by confocal microscopy.
I understand very little of what you just said. Maybe we should talk more about this.
I just need to know if 3 patients are enough. My grant is due tomorrow.
We will need to meet to better understand this before we can determine the appropriate sample size.
I can put you on my grant for 0.5% FTE. You can design and analyze the data later.
Do you really think that is enough to do the work?
Well, it may be less if it is awarded and the budget is cut.
Please go away.
Okay, so that's sort of a tongue-in-cheek explanation as to why we care about sample size, right? I have certainly had conversations that are maybe not quite as awful as that one. And I'm sure that some of you have had conversations that are along the same line. So we want to make sure that everyone is speaking the same language and understands what sort of information is helpful to our collaborators in order to come up with a design that meets everyone's needs. So again, a tongue-in-cheek explanation or example of why we worry about this. But from a scientific standpoint, we worry about power and sample size because we want to have a reasonable assurance that the trial has a reasonable probability of being conclusive. It doesn't make sense to do a study that you know is not going to collect enough data to answer the question. From a logistical standpoint, it allows us to determine the sample size that's necessary so we can efficiently allocate resources. And by resources, I mean patients, I mean investigator effort, and of course, the research infrastructure funding that is available is limited, and we need to make sure that we are expending it in a useful manner. There are also ethical issues with calculations of the sample size. If we do a study that's too large, then we're needlessly exposing some subjects to treatment when we could have answered the question sooner. And again, that's taking resources away from other questions that we could be exploring. On the other hand, if the study is too small, it implies the potential for misleading conclusions. And then again, one could argue that you're needlessly doing experiments on subjects when you are not going to be able to answer the question of interest. And there are examples of this from the literature. So this is one example that came up in our work within the Siren network recently. So this trial was published in the New England Journal of Medicine in 2015. It's the Therapeutic Hypothermia After Out-of-Hospital Cardiac Arrest in Children trial, which looked at children with cardiac arrest and randomized them to either therapeutic hypothermia or therapeutic normothermia for 120 hours. And the intention of this trial was to demonstrate that therapeutic normothermia would improve survival, therapeutic hypothermia would improve survival with a good neurobehavioral outcome at 12 months. The justification is provided for the sample size in the manuscript, and it says that the trial was powered to detect an absolute effect size of 15 to 20% improvement, and the sample size that's required for that effect size is 276 participants. When the trial concluded, the primary outcome results that were reported showed a 20% proportion of hypothermia patients survived with a good neurobehavioral outcome, compared with 12% of the normothermia patients. And the resulting p-value was 0.14. So the conclusions are appropriate according to the analysis plan and suggest that therapeutic hypothermia did not confer a significant benefit on this outcome. But that's, although it's technically true, it's a little unsettling, right? If you're the parent of one of these children, and it's possible that hypothermia confers even an 8% improvement in survival with a good neurobehavioral outcome, that may be considered clinically relevant. And in fact, the discussion portion of the manuscript addresses this, this limitation, which is that you can't really rule out a potentially important clinical benefit, despite the fact that the trial itself did not find one. And so we want to design studies in such a way that we are not left in this sort of limbo space where we see a clinically relevant treatment effect estimate, but we weren't powered to detect it. And so although the test itself is not significant, we're still left with questions. Okay, so now we're going to spend some time talking about the factors that go into determining sample size. And these, I'm sure many of you are familiar with: the level of significance alpha, which is pre-specified at the start of the trial. The power that you want to target, again, is pre-specified at the start of the trial. The minimum scientifically important difference, the variability in the response, and we'll talk a little bit less, but still bring up some issues related to the experimental design that could play into the sample size that's needed for a given trial. So first things first, before you can have this conversation about the sample size that's required for a given clinical trial, you need to know very clearly what's the research question. And the statistical collaborator that you're working with is going to ask for a very specific statement of that question in the form of testable hypotheses. And the reason for that is that all of these pieces tell the statistical collaborator what analysis you're going to be looking for at the end and what sort of design considerations might go into the trial. And so when you're stating this research question, we really want to know, what is the population of interest? What is the response variable? Is it a continuous measure? Is it an ordinal level, an ordinal scale that you're going to be dichotomizing, or could you use the full range of the ordinal scale? What are you comparing? Are you comparing a pre-post within a similar population, or are you comparing an intervention to a control group? And at what time point are you making this comparison? So it's often the case that in clinical trials, we capture data longitudinally, but we may analyze it only at the final time point, or we may analyze the full trajectory of the outcome assessment. So again, all of these things are necessary. And the statistician can help you to state turn your research question into statistical hypotheses. So there are two states of nature which we consider to be reflected by the two hypotheses that we state. So the alternative hypothesis, I'm sure all of you are familiar with. This is the easiest one to state, I think, because it's what you want to be able to conclude at the end of the trial. So in a typical superiority study, what you want to say is that the intervention affects outcome, and that would be your alternative hypothesis. The null hypothesis is that nothing is happening. It's what you want to contradict with the data. So if the alternative is that the intervention affects outcome, the null hypothesis would be that the intervention has no effect on whatever outcome you've specified. So the statistical hypothesis test in the frequentist framework is basically proof by contradiction, okay? We conceptualize nature as belonging to either of these states, the null hypothesis or the alternative hypothesis. They have to be mutually exclusive. The truth can't be a little bit of both, and they have to be comprehensive. There can't be any other explanation, right? So you conceptualize nature as belonging to one of these states, and then you collect data from the real world, and you look at the data in comparison to what you would expect based on the null hypothesis, the simplest explanation. So if your data clearly don't look like they came from the null expectations, then you're going to trust the data and conclude that the alternative hypothesis must be true. On the other hand, if your data are consistent with what would be expected as the result of random chance under the null, then there's no need to go with a more complicated explanation. You can maintain the simpler explanation, which is that the intervention does not have the desired effect. Okay, so we talked about the two true states of the null hypothesis? Well, we talked about the fact that they're mutually exclusive and comprehensive. And what you can take away from that is that the null hypothesis is either going to be true or it's false. There's not any in between, right? So there's two true states of the null hypothesis. And in the statistical framework, you can only make one of two decisions. You can either reject the null hypothesis or you can fail to reject the null hypothesis. The combination of these two truths and these two decisions leads you with four possible outcomes, okay? Two of these are correct decisions and two of them are mistakes that we want to try to avoid, okay? The first correct decision is that you reject the null hypothesis when in fact the null is false. So the intervention actually does do something and you are able to conclude that it does do something. And that's a wonderful thing, right? You write manuscripts, you present at conferences, and everybody is happy. That's the first correct decision. There's another correct decision, which is less exciting, maybe, but still important, which is that the null hypothesis is true. Your intervention doesn't actually work. And at the end of the day, you fail to reject it. You have to say, there's not enough evidence here to say that the intervention does something. It's not as exciting, potentially. There's some report of literature, of publication bias in the literature. And so these studies may not be published with the same frequency that positive studies are, but this is still a correct decision and we should feel good when we're in this situation. But we never know which of these situations we're in. And so the way that we go about designing studies is by choosing parameters for our statistical tests that minimize the likelihood that we make the corresponding errors that you see in this table. So the first error, again, I'm assuming that everyone is familiar with, is we refer to as the type 1 error or the level of significance alpha. So a type 1 error is defined by a scenario where the null hypothesis is true, the intervention has no effect, but the result of the statistical test is significant. And so we reject the null and conclude that the intervention actually does something. Okay, this is effectively a false positive, and we don't want to make this mistake very often. And in fact, we limit the likelihood of our being in this scenario by choosing something reasonable for the level of significance of our test. The other potential mistake that we can make is the scenario where the null hypothesis is false, so the intervention does have an effect, but at the end of the day, our statistical test is not significant. And so we are left to conclude that there's not enough evidence to demonstrate an effect of the intervention. Okay? This is referred to as a type 2 error. We don't typically think about setting the type 2 error, but we control the likelihood that we make a type 2 error by setting a target power for our trial or our study. So the power is defined by the probability that we reject the null and conclude that the intervention works when in fact it does. Okay, so we specify the type 1 error to control this mistake, and we set the power to control this mistake. Okay, so the first piece of this that we're going to start with is the level of significance alpha. And I am guessing that everybody knows that the most commonly specified alpha level is 0.05. But that's not a magical number, right? The level of significance in reality should be set by considering the interpretation of the level of significance and what the potential consequences of that error are in a particular disease area or for a particular treatment. So the interpretation of alpha is that even when the null hypothesis is true, we're going to conclude the alternative alpha times 100% of the time. So If we set it at 0.05, we're saying we're willing to accept up to a 5% false positive rate. Okay. Again, this is pre-specified in the trial design stage. 0.05 is not a magical number. But I want to show you how the impact of considering various alpha levels will impact potentially your sample size calculation. So we're looking here at a one-sided alternative just for ease of graphics. And what I'm showing you here is a curve that represents the distribution of the test statistic that one might see under the null. Okay, so if we've specified a one-sided alpha of 0.1, what we're saying is that any test statistic that we see in this shaded region is sufficiently inconsistent with the null to lead us to conclude the alternative. Okay, as we reduce the alpha level, that shaded region is going to get smaller. And so we are requiring more evidence to conclude the alternative. Again, think about what this means in terms of your study design. If you are trying to evaluate a surgery against medical management, let's say, and there's risks associated with the surgery, a test statistic demonstrating superiority out here in this region may not be enough evidence for you. There's risks associated with the surgery. It's going to take longer for recovery. You may want to limit your false positive willingness to something smaller. On the other hand, if you're evaluating a healthy diet, let's say, on some outcome, as a non-clinician, it's hard for me to think about what the downside could be to recommending that people follow a healthy diet. And so you may not even need a 0.05 level of significance. You may be willing to accept 0.1. Okay. Okay. The next thing that we're going to talk about is the power. And I mentioned this already. The power is the probability that a statistical test will find a difference when one exists. The tricky part about the interpretation of the power is that it's specific to a given value under the alternative hypothesis, right? So the power is not fixed for all possible treatment effects. You have to specify the treatment effect that you are interested in and come up with the sample size that achieves your target power at that effect size. So the interpretation is specific to that effect size. For a given value under the alternative, we're going to reject the null 1 minus beta, or whatever the power is, times 100% of the time. And it's related to the sample size. As you all know, I'll show you an example as to how these two parameters that we specify for our statistical tests work together. So in this example, I'm using a continuous outcome just for ease. I'm considering a phase 2 clinical trial in subjects with acute intracerebral hemorrhage. And the intervention I'm considering is intended to impact health-related quality of life. And we're using the NeuroQual to assess health-related quality of life. So the impact of the level of significance on the power is shown in this graph. So we have the total sample size that one might consider going along the x-axis. And we have the power of the test along the y-axis. And if I hold all other parameters in my design constant, the alpha level impacts the power such that for larger alpha levels, a given sample size will give me greater power, right? And this should make some sort of intuitive sense. Earlier, I said that if I reduce the alpha level, I'm making it harder to declare, or I'm requiring more evidence to declare that the alternative is true. And what that winds up meaning is that I need more patients in order to have a certain power. So you can see here, if I want 80% power, in this particular design, I can get that with 100 subjects at an alpha of 0.1. I can get it with a little more than 100 subjects at an alpha of 0.05, but if I'm going to do an alpha of 0.01, I'm out here closer to 200 subjects before I get that power. Okay, this is how they're related. That does not mean that alpha should be chosen in order to achieve a certain power. Again, alpha should be chosen based on the consequences of making that false positive conclusion. Okay, the next piece that plays into the power and the sample size is the minimum scientifically or clinically important difference. And we define this as the smallest difference, which would mandate, in the absence of serious side effects or excessive cost, a change in scientific practice or understanding. Okay, there's a rule of thumb about this relationship that is the larger the difference, the smaller the sample size. It's a little bit simplistic because there are other things that play in, as we just talked about the alpha level. I'm going to talk a little bit about the variation in a minute. But generally, again, what I'm showing you here is how this plays out in terms of the relationship between sample size and power. So sample size is along the x-axis, power is along the y-axis. And you can see that if I hold everything else constant, so again, holding alpha, holding variation constant, with 100 subjects, I can achieve 90% power for a mean difference of about 2/3. A half, my mean difference is a half, I only get about 70% power at that sample size, and so forth. So the power decreases for a given sample size as the effect that you're looking to detect decreases. Okay. Now, this rule of thumb, the larger the difference, the smaller the sample size, ignores the contribution of variability. And what I mean by variability depends on what sort of outcome you're looking at. So remember when I started this, I said when you state your hypothesis, we need to be very clear what the outcome is, and this is why. So if you're looking at a continuous outcome, then variation is described by an estimate of the standard deviation or the variance. If you're looking at a dichotomous or a binary outcome, then what we really need to understand the variability in that outcome is an estimate of the proportion of subjects with the outcome in the control group that you're going to study. Okay, so this is looking at the continuous example. I'll come back to the dichotomous in just a second. Again, the graph structure is the same, but you can see here that if my standard deviation is smaller, I get higher power for a given sample size. Okay. If we're looking at a binary outcome, so let's take the same phase 2 clinical trial in subjects with acute intracerebral hemorrhage, but let's imagine now an intervention that's not intended to impact health-related quality of life, but is expected to impact functional independence. And so we're going to define this using a modified Rankin scale score of 0 to 2. And for the purposes of this example, I'm assuming that the minimum clinically important difference is an absolute 10%. And I'm doing that just based on the stroke literature. The ischemic stroke literature seems to have accepted a 10% improvement in this outcome as reasonable. And so again, same structure, total sample size along the x-axis, power along the y-axis. But if my control group has only 10% of its patients achieving functional independence, then I have, let's go over here where I have more reasonable power. For 500 subjects, I have somewhere around 90% power. But as my control proportion gets closer to 50%, so here you can see I go from 10% of the control to 20 to 30 to 40. As that proportion increases, the power for a given sample size decreases. And again, this should make some sort of intuitive sense. The binary or the binomial distribution is most variable when the proportion associated with it is about 50%. You can think about that like a coin flip, right? If you have a coin that is evenly weighted, then each time you flip it, you don't really know what's going to happen. right? You're just as likely to get a positive or a negative. And so there's a lot of variability in the outcomes that are associated. If instead you're looking at a very weighted coin where it has a 20% likelihood of turning up heads, then when you flip it, you have a better guess as to how it's going to land, right? And so that plays out actually in this relationship between the sample size and the power. So if we're thinking about, again, this phase 2 clinical trial, in a superiority standpoint, the alternative hypothesis is that the treatment effect is not equal to 0, right? This is a two-sided hypothesis. The typical alpha level that one might assign is 0.05. And if my data suggest that 56% of the control group is going to have a good outcome, and I want to detect a 12% effect size with 310 patients, I only have 59% power. Now, some of you might be saying 310 patients for a phase 2 is kind of a lot. Maybe it is kind of a lot, but it still doesn't give me very good power to detect this effect size, which is pretty large actually for the stroke literature. And so one of the things that has been happening more and more recently, I think, is that trials, phase 2 trials that are set up like this are criticized as actually being underpowered phase 3s, right? Some of you might be in this sort of situation where you're designing a phase 2 study where you're looking for enough of a signal to tell you that it's worth moving the intervention into the phase 3 space. But you can't do that with a reasonable sample size. And so we pick a large enough effect size that it makes the sample size more manageable. But again, then we're opening ourselves up to this criticism. And I'm going to use this as an example to demonstrate how thinking and working with your statistical collaborators can lead you to some design considerations which might impact what you're trying to do. So there is a trial design that's referred to as futility that sort of takes this superiority study and flips it. Okay, so rather than saying, I want to show that my intervention has this huge effect size so that I can move forward, the futility study says, I want to show that my intervention has a sufficiently small effect size so that I don't have to consider it anymore. It's not worth my time. So the futility design is actually intended to weed out those non-effective interventions so that we can focus on the ones that have more promise. So the alternative hypothesis here, instead of showing, as in the superiority, that the treatment effect is not equal to 0, the futility design writes the alternative hypothesis such that the treatment effect is less than some threshold that you declare to be clinically meaningful. Okay. Written this way, this is a one-sided hypothesis. The typical alpha in the futility literature is 0.1. And again, that this is consistent with the consequence of making a false positive. A false positive in futility means that you will no longer consider an intervention which might work, right? Leads to a very different set of concerns than concluding that something works when it doesn't. So we could use a one-sided alpha of 0.1, same control group proportion assumptions, but now I'm designing the study to say if the intervention does nothing, really has no effect, effect size of 0, with 310 subjects, I have 80% power to say, forget it, I don't need to study it anymore. Okay, so very different justification, very different approach, but thinking about how your outcome is going to look, what you're going to conclude, what sort of design you're thinking about, all can help you sort of come up with the design that's really tailored to answer the question that you're asking. There are a number of methods for determining power and sample size. If you've taken statistics classes in school, you know that there are closed form solutions for many of the common two-sample comparisons under straightforward designs. many of the early phase research that is coming out right now, and some of the later stage research actually, though, is not based on a straightforward design. Okay, you might be thinking about dose finding or some sort of adaptive design. And in those cases, simulation may be the only way to determine the power and the sample size associated with a given approach. And what I mean by simulation is that we are going to generate a hypothetical trial lots and lots and lots of times and evaluate it and see what happens. So this is the phase 2 trial with a binary outcome that we just talked about. I can simulate one trial and see that the treatment group in that trial has a 60% good outcome rate. The control group has a 58% good outcome rate. I can calculate the risk difference, calculate the p-value. And I do that lots and lots and lots of times. And I track how many of those p-values led to rejection of the null hypothesis. And the power of the design then is the percentage of trials that reject. So in this simulation, I'm only showing you a couple of hypothetical trials here, but when we let this simulation run its course, what I get is a power of 57%, which is compared with the 59% on the previous slide from the closed form solution. Okay, so we've covered a lot already. So before talking to your collaborator about sample size, you want to be prepared to talk about the level of significance. You want to be prepared to talk about the target power. You want to be prepared to share some expected variability in the response. Hopefully that's based on relevant literature. Even better than sharing an expectation of the variability would be to provide a range of plausible values. So you can stress test whatever design you come up with and make sure that its characteristics are not adversely impacted by changes to your assumptions and the variability. You want to be prepared to talk about the minimum scientifically important difference. And again, that means what's the smallest difference which is going to change clinical practice. Oftentimes, especially when we're dealing with outcomes like survival, folks will say, well, even a 2% improvement in survival would be clinically meaningful. There are going to be lots of scenarios in which designing a trial for the minimum scientifically important difference is going to make the sample size not feasible. But when you start there, there's room for compromise. And then you can think about, okay, I can't do that. What if I bumped it up a little? What if I bumped it up a little? Or what if I made some changes to impact these other assumptions that I'm making? And so one of the other things that you can consider are the experimental design. So considerations, we've already talked about changing from a superiority in a phase 2, which could be criticized as an underpowered phase 3, to a futility approach. You might think about whether a parallel and concurrently run control group is really necessary, or whether you can use some historical control data to evaluate your assessment of the intervention. You might consider whether multiple questions can be answered in the same design. Okay, this may not be sample size savings in a particular trial, but over the development cycle, it could have sample size saving implications. You want to think about whether a hypothesis test is really the best way to achieve your goal. If you're evaluating multiple doses of an agent, to pick one, you could do a design that does a hypothesis test to compare each dose to a placebo, but that may not be the best way to move forward. If you want to pick a dose, maybe some sort of selection methodology approach is better serving. Is the design adaptive, and what specifically are the adaptations that you're proposing? And the sample size calculation is going to depend on the method of analysis, which depends on the design. So again, all of this is sort of tied together, and it needs to be part of that discussion. And just keep in mind that for some designs, simulation really may be the only way to determine the design or the sample size. And if that's the case, there's legwork that's involved in determining the sample size and those operating characteristics. So you want to make sure that you've approached this conversation early enough that you have time to do that legwork. Okay, so here's an example. I'm not sure if you all can see this thing that's at the top, but so we're taking patients, eligible subjects as the box, which maybe you can't see at the top. And in this particular design, we're randomly assigning patients to a placebo and one of 4 active doses. And the outcome is observed relatively early. It's at 24 hours, we're looking at RV function on echocardiography. And the adaptation that we've specified here is that after the first 150 or 200 patients have been randomly assigned, we're going to look at the primary outcome, and we're going to use the outcome information to come back up here and change the randomization vector, or the probability with which subjects are assigned to each of these doses. The idea behind that is that we'll be getting more patients in doses that look good and less patients in doses that don't look so good. And that should give us a better sense as to where our target dose really ought to be when we're ready to move forward. But the only way to evaluate this particular design is through simulations. And the way that we do that is by hypothesizing truths. So I'm just showing you a small snippet of work that was done in developing a planning grant for this particular design. So we've specified here a null hypothesis, which is that dose changes and nothing happens on the primary outcome, and an alternative hypothesis that looks like a linear increase and then sort of a plateau at the highest dose. And again, we're going to generate these hypothetical trials and track performance and see how the parameters that we've specified actually work in practice. So under the null scenario, where the treatment does nothing, what you can see is that dose 1 is selected more often than dose 2. Okay, and that's a good thing. So we're selecting lower doses more often than higher doses, but that it doesn't really matter because we have essentially no chance of showing the benefit of the selected dose. Okay, so that performance looks pretty good. Under the alternative scenario here, what we're showing is that dose 3 and dose 4 are selected with roughly equal probability. Okay, the design is having a little bit of a hard time deciding between these two, which kind of makes sense under these assumptions because they're plateauing. So sometimes it's going to be able to pick 75, sometimes it's not. And you can see that the probability that we declare benefit of the selected dose actually does increase with increasing sample size. Okay, but there is some point of diminishing return, right? So we see a reasonable increase here. So we probably don't want to just use 200 subjects for this purpose. But here, now we've gotten to 600 and we see that we can go all the way out to 800 without much improvement. And we're just getting a little bit better as we go. So maybe 600 is the sweet spot. Maybe that's the magic number. Okay. After you've done all of this work, you need to carefully consider how to justify the sample size. So you need to specifically state how many subjects, how did you come up with that number, and is it adequate for testing the hypothesis? So if you need more, why aren't you asking for more? And if you could answer the question with fewer, why are you not asking for fewer? There are two different ways that this is typically explained. The preference, of course, would be to specify all of the things that we've talked about and then calculate the sample size that is needed. Oftentimes you do that and you say, well, I can't afford that many patients. Or maybe that many patients don't exist in this particular patient population. So an alternative way to do it would be to specify the sample size that's available to you based on resources, specify the power and the variability, and then you can calculate the difference that is detectable based on those limitations. There is freeware available on the web. I should have checked these links before I presented them. I didn't. So if they don't work, please let me know, but there are plenty of them available. There's purchase software that's available, and your statistical collaborators will have lots of options in addition to those that I've listed here. Okay, so we've talked about all of these things. The last thing I'm going to say about sort of factors that go into this are the logistical considerations. What is the anticipated recruitment? How likely are treatment crossovers? What sort of protocol non-adherence might you expect? Do you anticipate lots of loss to follow-up or consent withdrawal? And are you planning to look at the data in the interim to make some sort of decisions? All of these things require adjustments to the sample size that you've determined based on the previous factors. So be prepared to talk about those as well. And I'm going to end with this quote from Russell Lenth, who was a professor at the University of Iowa. This was taken from his website a number of years ago. He said, "I received quite a few questions that start with something like this. I'm not much of a stats person, but I tried XYZ. Am I doing it right?" And he said, "Please compare this with, I don't know much about heart surgery, but my wife is suffering from XYZ and I plan to operate. Can you advise me?" Okay, it's just really not a great idea to just plug numbers into a program unless you really understand what's going on under the hood. And so don't be afraid to reach out to statistical collaborators, reach out to your small group leaders here, reach out to me, reach out to anyone for that connection with a statistical collaborator, because it will be worthwhile for both of you. Okay, and I will stop there. Do folks have questions?
If anybody has questions, you can put them in the chat, the Q&A, or you can raise your hand and I can allow you to talk as well.
It's like Fiona has like her hand up. Can she speak, or does she have to, is she typing it somewhere?
You should be able to speak now, Fiona.
I just was wondering if you could talk a little bit more about interim analyses and sort of, I mean, I've heard about them before a little bit, but sort of their effect on that, and maybe just a little bit about how to think about those, like
Sure.
as a first shot for someone who's trying to like do like at least the initial prep work to think about how to set up this type of power analysis.
Sure. So interim analysis is fairly common in definitive trials, maybe less so in earlier phase trials, although I should caveat that by saying it depends on what you mean by interim analysis, right? So if you're doing an adaptive dose finding design, after every couple of patients, you're doing an interim analysis to determine where the next couple of patients might go. But the consequences are a little bit different. So again, I'm going to try to sort of focus on the phase 2 superiority, but if you want to talk about something else, feel free to shoot me an email. I'd be happy to do that.
Thank you.
So in the superiority setting, if you're doing a definitive clinical trial, the funding agency may require you to do an interim analysis for futility, which means that you want to look at the data at some earlier time point and decide whether or not it's worth letting the trial go to its conclusion, right? So if you look at half of your outcomes, when you have half of your outcomes and there's no difference whatsoever, may not be worth continuing to enroll patients to get to the end sample size. So that's one possibility. The other possibility is that you may schedule an interim look to determine whether you've already shown that your intervention works. So again, at half of the outcomes, when they're available, you may do an interim analysis and say, gosh, my test statistic is 17, right? There's a huge difference in these outcomes. And so I don't need to randomize the rest of my patients. The consequences of those two analyses are different. So both of them will have some impact on the sample size. But for the case where you're allowing stopping for efficacy, what you're doing is you're spending a little bit of that type 1 error early. And so it's harder to stop early than it would be to stop at the end of the trial. If you're doing an interim analysis for futility, you're spending a little bit of the type 2 error early. And so that is likely to have a larger impact on your sample size, because even though you've looked early, you want to maintain the power at the end. Okay, so you probably don't want to do it too often. And you do want to consider when is too early to do it, when is too late to do it. Both of those things are going to have impact on the sample size. So you definitely do want to consider which of those are necessary. And as a pet peeve, if it says anywhere in your grant application that you're going to do it, you should address it somewhere in the statistical section.
And so, for example, like when you're saying if you're looking for, you've achieved the outcome early, your ultimate p-value has to be smaller. So
yes. Mm-hmm. So at the end of the trial, if a p-value of less than 0.05 would be significant. An early efficacy p-value, according to a typical alpha spending function, might be less than 0.0001. Again, it depends on where you put it, how many patients out of the total and things like that. But it's generally much harder to stop early for efficacy than it would be to declare efficacy at the end.
And if you were stopping for futility, you're saying that you need a bigger sample at the end, or you need to have.
Yeah, so the power will be affected more if you do a futility analysis during the interim. But in the interim, what you would be saying is basically if the two groups are closer than some window, right, then you would say this is not worth it. There's no point in going forward.
Thank you.
Mm-hmm. Any other questions?
I do not see any other hands raised or anything in the chat or the Q&A. I did put Sharon or Dr. Yeatts' email in the chat box if anybody needs to reach out to her. I also put a link to the evaluation. If you can please take that so we can improve future webinars. We really appreciate it. It will only take a moment. And if there are no other last minute questions, I think we can give you guys back 5 minutes. Thank you so much, Dr. Yeatts, for your time. We really appreciate it. Everybody have a great day.
All right, take care.
Bye.
Thank you.
Bye-bye.